All right, guys, we're going to divulge into our cerebellum and basal ganglia systems today, focusing on the motor aspect of these systems. This is going to be chapter 15 and 16 in your Lundy-Ekman book. And here are our objectives. Essentially, we're just going to really understand the main structures and functions relating to these two structures and how they impact our motor planning. There are a couple tracks that we are going to go through. Anterior and posterior spinocerebellar tract is the main pathway we're going to be going over. And then the biggest thing I want you guys to know within this spinocerebellar tract is that we have high fidelity and low fidelity. High fidelity and then these internal feedback tracts. And this mimics kind of similarity of our spinothalamic tract, how our lateral spinothalamic tract is that fast, precisional location versus more of that slower, dull ache of that medial / anterior spinothalamic tract. Medial or ventral. So we're going to get going and talk about the cerebellum. So on slide 4, we're discussing the basic gross anatomy. Now, a little bit of information about the cerebellum is that it's also called the little brain. Now, in comparison to its big brother, the cerebral cortex, this little brain is about 10% of our mass. However, it is made up bulkily of gray matter folded together. So it's this small little brain, but the gray matter is folded and folded, where I found this fun fact that if you take and unfold that, it's about 1 meter and 10 centimeters long. So I thought that was really interesting that this small thing can be such a big thing when it's unraveled. And so alongside that gray matter, it's made up of white matter, and that white matter is myelinated axons again, where they're going to and from the cortex. But that white matter substance is called that arbor vitae, or that tree of life, as we can see in that cross section on this image on this slide. Excuse me. That arbor vitae is that white matter being shown in there, that tree-like formation. But the main location of the cerebellum is it's inferior to our occipital lobe and it's posterior to our brainstem. And as we can see, mainly kind of around that pons area of our brainstem. And then we can see our canal for our ventral system. Our fourth ventricle is that small kind of indentation where our fourth ventricle lies. Sorry, I had a train of thought there and I just kind of stopped. All right, so the structure has 2 hemispheres, and each hemisphere is connected together by this vertical structure called the vermis, which we'll talk about in a couple slides. But the 3 lobes are the anterior, which is that pink purplish color, posterior, which is that brown, and then our flocculongular lobe. It's kind of fun to say. Flocculongular lobe is that small, most inferior aspect, more medial towards the brainstem. So there's 3 lobes, and within each lobe they have specific kind of ideal functionings. So the anterior lobe is a lot of along the lines of connecting our sensory input from our spinal cord. So it is that main kind of information coming from our sensory information from our lower motor neurons and our skeletal muscle into our spinal cord. The posterior, however, is involved with a lot of connection and output from the cerebellum, and it's the largest aspect of that part of each of those lobes. And our, our flocculongular lobe, that's going to be involved with our inner ear vestibule connection of our equilibrium. One little, excuse me, this cerebellar tonsil, I put this in here because I think it's kind of an important clinical relevance. I didn't really know about this. I had a couple patients one patient in particular, excuse me, that had something kind of similar to this. So the cerebellar tonsil is the most inferior part of the posterior lobe, and we think about how our brain is set up. We have that foramen magnum, which is that big hole at the base of our skull. And what happens is that this tonsus cerebellum, if there's an elevated intracranial pressure, what happens is that this structure is getting forced through our foramen magnum. So it's a typical thing is called herniation. So anytime you see a herniation or hear about a herniation in the brain, it's not a good thing. So if we think about a hernia, when we're having that protuberance through our inguinal canal in our abdominal area, it's kind of the same similarities of that pathology, but in our brain, and that's not a good thing in any sort of sense. Where here, this herniation, it actually causes breathing and pulmonary dysfunction as well as cardiovascular impairment. And so what happens is that this structure is basically just being pushed through our foramen magnum, and it's not a good thing. So in the book it talks about this a little bit. So I thought I would just put this in the slide just to kind of discuss how this cerebellar tonsil can cause a lot of impairment with our vital functioning, our autonomic regulation, if we have an increase in our ICP compromising that fourth ventricle because of the closeness related to our fourth ventricle, where both are that anterior placement of our fourth ventricle from our cerebellum. So our cerebellum has both lobes and this vertical layering. And this vertical layering has this vermis, which is our midpoint. So it's an unpaired structure. So you're not going to see two of these like you'll see the paravermis on each side and then our lateral hemispheres, which is our largest. So our vermis is being able to aid in our midline posture, our movements, and our eye movements. And if we think about how our body is set up, this vermis is kind of like our axial skeleton. So on our axial skeleton, we have our head, neck, postural control. So that's how you can kind of associate this vermis to its function, is its ability to look at its structure within the cerebellum. And that vestigial nuclei, I just put that there because that's the connected nuclei that this structure goes to within the cerebellum. So just putting the vertical structure along with the nuclei. Now our paravermis involves a lot of our movement through our proprioception. So that's getting input of movement-related proprioception essentially. And then our hemispheres, which are the largest, this is what influences a lot of our output to the motor cortex. And if we think about the previous slide, when we look at how large the posterior lobe was and that relationship to our nerve impulses from the cerebellum, back on slide 5, that lateral one associating with output to our motor cortex makes sense because that's where we're having a lot of that cerebellum do the work. And that nuclei is our dentate nuclei. Okay. So now we're going to talk a little bit about the cellular anatomy because of these cool things called Purkinje cell bodies, but the main layer is our gray matter, which is our outer layer. And then inside, we're going to have 3 layers, but the inner and the outer layers are mainly our inner neurons. And our inner neurons, again, are that reflexive component of that interconnection discussion, kind of like how we were talking about in our spinal cord, those inner neurons are our reflexes. The same concept is here in our cerebellum. But our Purkinje fibers is that middle layer, and they're the largest in the brain. They're the longest. And what they aid in is that deep connection to our deep cerebellar nuclei, and that helps with aiding in our descending tracts. And again, the purpose of the output for that cerebellum, so that makes sense because descending is our motor movement. And also, the Purkinje fibers also have the most dendritic trees within our central nervous system, or our nervous system, excuse me. So you can kind of see on this image that Purkinje fibers, how many dendritic trees are there connecting up to that gray matter, that inner layer. And within our cellular anatomy, we have presynaptic fibers and postsynaptic fibers. And within our presynaptic fibers, there's two main other neurons. We have these mossy nerves, and these mossy nerves are essentially our somatosensory information that goes to our brainstem and the spinal cord. So again, that mossy is being able to provide somatosensory input to the brainstem and the spinal cord. And then our climbing one, which makes sense, is movement error. So if you think about association terms with this, is that mossy is kind of this moss, and it's allowing for information with touch, pressure, and then the climbing ones, because when we climb, we use movement. And our postsynaptic fibers is essentially just those deep nuclei, providing with the information transmission, the neurotransmitters to aid in the function of our cerebellum. So on to that topic of cerebellar functioning, we have some big roles that it plays. On top of the incorporation of our inner ear and our vestibular system, equilibrium is a part of our cerebellum, being able to manage our ability to stay upright against gravity. Now we have gross movements in the limbs it helps with, as well as that precisional fine motor control, or our voluntary distal movements. It also aids in regulation of muscle tone and modulating the input from our brainstem and our spinal cord. So that's another important thing too, is the muscle tone regulation. And within this function, there's three specialized regions. We have our vestibulocerebellum, pardon me, my phone, our spinocerebellum, and our cerebrocerebellum. So I highlighted or bolded that spinocerebellum because that's when we're going to see our superior and posterior cerebellar tracts come into play. All right, so let's divulge into the vestibulocerebellar region. So this is also the location of our flocculongular lobe as one of the lobes of the cerebellum, and the main encompassment of this structure is regulating equilibrium. Within the name, we see vestibulo, which is our vestibular system, and our cerebellum. So we can kind of identify through the word what its function is going to be. Now, it's important to note that all three of these main functionings of the cerebellum is going to be ipsilateral information. So I bolded that because our brain, cerebellum, is a bit different than our cerebrum, and that in our spinal cord tracts is that it receives same-sided information. So everything kind of goes out the window when we think about how our cerebral cortex is contralateral. Now we're going to be getting ipsilateral, same-sided information. And it also corresponds with the same-sided vestibular apparatus. So it's integrating both our vision and our vestibular system for that head, posture, and eye movements. And when we have dysfunction in this, we're going to see unsteadiness. Now, an example of this would be like when we're reaching up above, say in a high cabinet for something, our arm is providing that open chain movement while our body is remaining steady with our head and our posture so we don't fall over when we're moving. It's allowing for axial support. So on slide 10 on our spinocerebellar functioning, its main purpose is coordinating gross limb movements and including that axial skeleton support as well. So this is allowing information from our limbs, such as touch and pressure from the spinal cord. And that main location is within that vermis and that paravermis. And again, our vermis is that head and postural control with our vision input. And it makes sense, we're getting information spine to our cerebellum. So that first component of the term, it's going to aid in helping you identify where the information is coming from and how it's encompassing movement. Now, this is when we're going to see a lot more ataxic, jerky limb movements. And within this system, we're going to see these high fidelity tracts, so those fast acting tracts in the spinocerebellar, which is particularly our posterior, and our cuniocerebellar. So that high fidelity, again, is that somatotopically arranged information, that precisional information of location, and being able to get that information very quickly and organized based on how it's being perceived with movement. Now, the main location for both of these tracts, the posterior spinocerebellar and the cuniocerebellar, is going to be in our columns, our white columns. Now, on our slide, we can see our posterior cerebellar our posterior cerebellar pathway is going to be in that lateral column. Now, in that slide over, or in that picture over on the right, we can see that posterior one is mainly kind of in that posterior lateral positioning. And then our cuniocerebellar is going to be in the posterior column, which is not mentioned in this on this picture in particular. It's just associated with in your book for the spinocerebellar functioning. And the reason why these two are associated is because of how they receive information. Now we're getting unconscious proprioception, so this is where we're going to see that Clark's nucleus play in. And we're getting from our deep Golgi, from our muscle spindles, our Golgi tendons, for our Pacinians or Meissner's information, or Merkel's, we're getting all that information of our proprioception, and it's coming to the same side of the limbs that it is getting information from. And so our posterior spinocerebellar is getting information from our lower body, and then our cuniocerebellar is getting information to our upper body. So here we're going to talk a little bit about the flow of the spinocerebellar. So since it's kind of more of there's not really a 1, 2, 3 type of flow. We're just going to talk a little bit about just how it flows instead of breaking it down 1, 2, and 3. So our purpose of our posterior spinocerebellar tract, is that unconscious probe from our lower extremities and our trunk. So we're getting branches from our skeletal muscle, from our Golgi tendons, our muscle spindles, and what they do is they come in through our peripheral nerve, so our lower motor nerve, going through that dorsal root ganglion, and the first synapse occurs at our Clark's nucleus and our dorsal gray horn, or our Clark's on the same side, our Clark's nucleus on that dorsal gray horn on the same side of the information it gets on the same side of the spinal cord. Then what happens is the axon then kind of flows out of that dorsal gray horn and just goes vertically or ascending up their spinocerebellar tract all the way through that lateral column that we saw on the previous slide, and then just right up through our inferior peduncle and straight into the cerebellum. Now, our inferior peduncle is going to be excuse me one second. I had a quick note I wanted to talk about that real quick. The inferior and middle peduncle is going to be getting, let me backtrack. The inferior cerebellar peduncle is going to be our afferent. So we're going to be getting sensory information up in through our post-inferior cerebellar peduncle. So when we go through that inferior cerebellar peduncle, we're going to be getting information about our sensations to the cerebellum. Okay? And that's essentially the posterior cerebellar tract. It's getting unconscious prop from our lower body, coming up through our spinal nerve, going through our dorsal root ganglion. First synapse is within the Clark's nucleus. That axon then goes out of the gray matter into our white matter lateral column and ascends up that tract, up through our midbrain, up through our medulla, our pons, our midbrain, does not hit any nucleuses and just goes straight through that inferior cerebellar peduncle, and then it synapses in the cerebellum. And so that would be the blue one that we see within our little image here, is starting, say, in our quad, going to our spinal cord, and then just go straight up through to our cerebellum on the same side. Now, our cunicerebellar, again, is unconscious prop too, but it does not get any specific specialized nuclei like the posterior spinocerebellar. It's essentially getting information from our arms, upper trunk, neck, and this flow is very similar too. So this is going to be the green one that we're following. So we're getting information. We're getting information from our lower motor neurons coming to our medulla. So this one, it comes into our medulla. So it's going to come in through the spinal cord and then just ascend right up into this lateral cuneate nucleus where it has a synapse, and then again moves same-sided to our inferior cerebellar peduncle, and then synapses within the next axon in our cerebellum. So we're coming in through our lower motor neuron from that cervical cord segment, coming in through our dorsal root ganglion, coming into that dorsal gray horn, not synapsing, but then just moving up through our tract, then synapsing on that lateral cuneate nucleus in the medulla. And then that next axon is going to be going same-sided through the inferior cerebellar peduncle and then into our cerebellum for our next synapse into the specific information it needs to be understanding. Now again, this is unconscious, okay? So pause, rewind, go back and listen, follow it with your finger as I talk. That might help with seeing this movement and relaying it and making that connection. So within our spinocerebellar tract here on slide 14, we also have the internal feedback loop. And again, this is kind of that slower, kind of less of the high fidelity ones that we've seen, because this monitors essentially our inner neurons and our descending motor signals coming from our cerebellum, coming from our cerebrum and our brainstem. So the one that we have here is our anterior cerebellar tract. And that anterior cerebellar tract, as we can see, is along that lateral white column segment of our spinal cord, but just a little bit more anterior than the posterior one on the lateral aspect of the white columns. And the purpose of this is going to be relaying spinal reflexes and proprioception to the spinal cord and any muscle activation that's controlled by our inner neurons. Excuse me. Okay, so the purpose of this, again, is having information coming from proprioception and attempted movements from the leg and the cerebellum. So this anterior spinocerebellar tract on this image is going to be this purple. Now this one does cross over, but then it crosses over again. So this one can be a little confusing too. So make sure you're pausing this and going back and re-listening to it as well. And I can answer any questions too in class if there's any misunderstanding of anything. So again, that flow is coming from our lower motor neuron, and that input goes in through our spinal nerve, through that dorsal root ganglion, and then it goes right into our anterior horn. Okay, so this information isn't necessarily going to that posterior or dorsal gray horn because its association with the motor or efferent movements, those descending tracts. So this one is going to first synapse within the within the anterior gray horn of our spinal cord from our lower extremity in this example. So what happens is then it crosses over or desiccates via this anterior commissure, which is essentially just this collection of white matter for axons to kind of allow that flow to go through. And then it comes onto that lateral anterior white column. And then it ascends up through the spinal cord, our lower medulla. And then it then can do one of two things. Majority of the time, what it does is it comes through the superior cerebellar peduncle. Then it goes within that, it crosses back dorsally behind the structure and then synapses on the same side of the cerebellum. So usually it crosses back over, so it's maintaining that same-sided or ipsilateral information. In this image and in the book, it talks that it can either stay crossed or stay as the contralateral side, or it goes back over to its same side as the initial stimulus. Now in the image, that purple one, which is on the left side of the figure, as you can see, it's coming into that anterior gray horn. Sorry, I had to take a drink. I had something in my throat. So it's coming through that anterior gray horn, that information. So let me backtrack too. I said it came through the dorsal root ganglion. That's not correct. What it's doing is this neuron is coming straight into our anterior gray horn. It crosses over via that anterior commissure, ascends up through those white columns on the lateral aspect of that lateral white column structure of our spinal cord, ascending up through our brainstem, then coming into our superior cerebellar peduncles, closest to our midbrain. Okay. Then it goes in one side, and then it flips back around, kind of doing like a behind the scenes movement, and comes in synapses on the same side of the same stimulus. So it still provides ipsilateral information. Even though it crosses at one point through that anterior commissure, it majority of the times then recrosses back in our cerebellum. So it's kind of this driving car that likes to take many detours to get to our cerebellum. It's kind of a confused driver, this anterior spinocerebellar tract, okay? So pause, rewind, re-listen to it, but I'll say it once more. So our information, our peripheral input is coming directly to our anterior horn, our anterior gray horn, because it's aiding in descending tracts. It's then crossing over or desiccating through that anterior white commissure tract, and then it stays within that lateral white column of myelinated axons, going through our medulla, going through our pons, coming through our midbrain, going into our superior spinal peduncle, our superior cerebellar peduncle, and then goes around and back behind and comes to the same side. So it's a crazy driver, essentially. But damage to the spinocerebellar tracts is when we're going to see a lot of ataxic movements, but not due to a strength impairment. It's all due to that unconscious proprioception and our inability to coordinate smooth movements because of that. And that's why it's difficult to assess which specific tract is doing the damage, because they're rarely occurring individualized. They're always occurring together. So you can't piece through that when we see a cerebellar stroke that, oh, it's through the posterior cerebellar tract, because they work in unison, and that it's all unconscious, just different directions to get there. Now, Friedreich's ataxia is an inherited disease where you're seeing the dysfunction within the spinocerebellar tracts. So the two videos on the slide, I want you guys to go and watch, and you can see how Friedreich's ataxia is impacting stair maneuverability. And with Jared, it's talking about showcasing, it's a news article showcasing a little bit about how he functions. I like how it shows he's getting in and out of the car. He can walk, it's just he's so uncoordinated because of that ataxia that he can't stay upright. So the wheelchair is the safest forms of mobility for him. And so I want you guys to watch that. But remembering it's an inherited disease, this Friedreich's ataxia, it can occur usually in 1 in 50,000 people, and it can start at a young diagnosis. So it's a very sad condition, and you don't have any loss of cognitive functioning. It's all just motor control. And tactile sensation can be lost at times too, but that's Friedreich's ataxia specifically. But damage to the spinocerebellar tracts through a acquired involvement would be MS, which would be multiple sclerosis, stroke, tumor removals, and actually alcoholics can experience damage to these tracts due to chronic use, because with that addiction, we're just getting more and more debilitation and degeneration of these neurons providing this input. So all of that was our spinocerebellar tract. So we've gone through our vestibular cerebellar section, our spinocerebellar section, and now we're going to go into our cerebrocerebellum section. And this is that green showcasing in this figure, and essentially it's that somatotopic kind of, if you can see that organization, it's essentially giving that perception of precisional movement, or movement coming from our cortex to initiate and plan our movements. And this is located in our lateral hemispheres of our cerebellum, along with our connection to our cerebrum, or our cerebral cortex. So this is when you're going to see a lot more clumsiness in especially our distal movements. So for instance, if you are grabbing for something, you have that plan, you're goal directed with precisional movement, because I want to go grab my pencil. I'm using my visual spatial influence to go and grab that pencil. I'm using my timing to make sure I'm coming at it at a smooth and accurate time. But what happens is that when you go to grab it, you can't, this clumsiness feeling starts to happen. You're unable to correct or figure out how to keep it within your hand. So you're going to see more clumsiness within our distal extremities with involvement here. And I'm going to have you guys review the table on 15.2 and 15.3. It gives a good kind of breakdown of the functionings, the vestibulocerebellar, the spinocerebellar, and the cerebrocerebellar in regards to how dysfunction can occur too. So please review those. So cerebellar dysfunctioning. So what we're going to see is same-sided involvement, except for that superior spinocerebellar tract, depending on if it doesn't cross back over. But typically, majority of the time, it is this same-sided lesion, the same-sided impairment. So we're going to see abnormal motor execution. So remember, this does not change with or without vision, like our somatosensory system. Vision aids in providing more control. Here in the cerebellum, it doesn't matter if you have your eyes open or have your eyes closed, it's going to be the same performance. And also, individuals with this have normal strength. It's not strength that's the issue, it's our understanding of our position in space. So what happens is that we're going to have impaction of posture, automatic movements, voluntary movements, and our eye control. So ataxia is a common clinical condition that we're going to see, and we get this thing called truncal ataxia. So truncal ataxia is caused by the influence of that flocculongular or that vermis vertical lesion. And this is when we're going to have a wobbly head and neck when we're trying to be steady. So truncal ataxia, so just think of just a very kind of wobbly, noodly appearance, essentially. You're going to be kind of like a noodle, just because you can't stay coordinated. We're going to see gait disturbances. This usually occurs in the paravermal areas within that vertical structuring. And typically what you'll see with these people, or with these individuals, is kind of a wide base gait. So they're going to be, instead of having our shoulders over our hips and our ankles, you're going to see an outflare of their legs to improve their base of support. So they're going to have a wider base of support to improve their center of gravity. So that's typically what you'll see not only with walking, but also just in static standing. And then we're going to see difficulty with reaching in our upper extremities, more clumsiness, and this is a lot of the times due from that cerebellar region for our ataxia. And then nystagmus, as we've learned in chapter 21, is that abnormal eye movement, that jerky eye motion. We're also going to see dysarthria, dysdiadochonesia, which is a fun word to say. Practice that one and say it 10 times. But dysarthria, again, is that poor articulation of speech. So I've included at the bottom links of below showcasing what these mean. So please view those on your own time. But this dysarthria, slurred speech, kind of drunk talkers, because they know what they want to say. They understand what you're saying. It's not an aphasia. It's just poor coordination of the tongue and the muscles to be able to talk. Now, dysdiadochonesia is inability to do rapid alternating movements. So in the video, when you watch, you're going to see someone going from supination to pronation, and how we move that as I'm doing it while I'm talking, that's funny, is very smooth, coordinated movements. Now in the video, you're going to see more jerkiness and the inability. And Professor Zizai, and more of this will be going over in the lab on Friday. So dysmetria is this inability to kind of accurately hit a target when you're reaching for it. So overshooting can be seen, and this is not due to a visual spatial issue. It's due because of the inability to accurately time and have that position. And then an action tremor is when we're going to feed ourselves and we're reaching for that. We have this volitional, motivational wanting to go and reach for it, and then we just start to have involuntary jerky movements. So eating would be hard with this type of tremor, and you see this often with cerebellar lesions. So here on slide 20, this is just ultimately the the summary of the cerebellum. The biggest points is just understanding how the cerebellum is involved with a lot of unconscious interpretation. And it's hard to separate out which tract is causing this ipsilateral, same-sided, involuntary movement, okay? So it's important for our cerebellum because it provides our movement and our postural control and how our limbs interact with our environment. And it's important to note too, again, as I said previously, that lesions to the cerebellum usually do not involve a loss of strength. It is a loss of understanding of position and proprioception. Okay? And this is important to know the difference between this somatosensory ataxia versus cerebellar ataxia. And that, again, that somatosensory ataxia is improved with vision and decreases when vision is occluded. However, with cerebellar ataxia, it's ataxic no matter what, okay? So it's important to kind of know that differential diagnosis. All right, we're going to move on to our basal ganglia. If you need a pause, go get some snacks, go ahead and do it. And we're going to start with this kinetic system. And essentially, our basal ganglia is that. It's a facilitator of movement, but it inhibits movements that are competing against it. So we have very smooth movements, okay? Kinetic means related to or resulting from motion. So our basal ganglia, as we've learned, has a big role as a blueprint for our volitional control. So we're responsible within this structure for speed and skill, balancing inhibitory and excitatory impulses. So again, inhibitory is stopping that competing movement. For example, if I'm going to go reach, I'm going to extend my arm out to go get my pen from my container here. What's happening is my arm is extended, and my inhibition of this basal ganglia is not going to allow for my biceps to flex while I'm reaching. So it's an important component of inhibiting muscles while one is activating. And it also, as we learned from our neuromodulation and our limbic system, is the connection with our judgment, our learning, our eye movements, and those emotional behavioral loops, which we'll talk about soon. So for this structure on the figure below, I just want you to remember that it's at the base of our cerebral hemisphere spheres, and we have three structures. We have our three in the forebrain, which are going to be our caudate head, caudate body, our caudate tail, so our caudate essentially, our globulus pallidus, okay, and then our putman is the other one. And then we have one in the diencephalon, which is our subthalamic nucleus, and then one in the brainstem, which is our substantia nigra. So I'm going to say that again. The three structures in the forebrain are our caudate, including the head, the body, and the tail, our putamen, and our globulus pallidus, internus and externus. But I just want you to know the three: caudate, putamen, and the globulus pallidus. And then the diencephalon is our subthalamic nucleus, and our brainstem is our substantia nigra. So in the basal ganglia, what happens is these structures then form to make kind of their own subgroup. So these arrows pointing to specific ones, like our caudate nucleus and our putamen are going to be, or putmen are going to be in our striatum, this group called our striatum. But then the putmen also works with the globulus pallidus and this lenticular form nucleus. So just want you guys to know how these two or four structures, these two different subgroups, and what they compose within the basal ganglia. Now the caudate is going to be this C-shaped, as we can kind of see with that head, that body, and the tail. And our subthalamic nucleus, I've already mentioned, is in the diencephalon. But the biggest outputs of the basal ganglia are going to be our, are going to be the globulus pallidus. The globulus pallidus, is going to be a lot of inference with our output of movement to our brain, from our basal ganglia, But the biggest thing with the basal ganglia is that the majority of everything is a nucleus. Kind of like our thalamus, the structure is mainly nuclei. Okay? And on slide 24, this is just showcasing a little bit of a coronal view. When we get to go looking at MRIs in the clinical setting, you may see images like this, but it's just showing you another section of how the basal ganglia is located on each hemisphere. Okay, so we do have pairs of these structures, of this structure, But the biggest thing with the neurotransmitters involved, I just wanted to bring back in our neurotransmitter information, is dopamine, which is going to be excitatory, which will be important to know when we get into the pathology or the dysfunctioning of our basal ganglia, and acetylcholine is inhibitory. So these loops, I'm not going to spend a lot of time going over the three non-motor loops, because we've already discussed this in the limbic system, but then again, I have put those back into this as a review, because as we know, when we see things multiple times, it's important to grasp that knowledge for learning. So in all, these basal ganglia loops, there's 5. There's 3 non-motor and 2 motor. So in the graph below, I'll have you guys, those have the specific locations of the 3 non-motor in regards to our cerebral cortex, our basal ganglia, and our thalamic nuclei. So as a quick refresher for that goal-directed behavioral loop, it's allowing us to make informed decisions within that context, and it aids in reward learning. So an example in the book it kind of talks about too is you're driving in your car, you have say an appointment to get to, but you're running late, and you approach a yellow light. What do you decide to do? Okay, so this goal-directed behavior is being influenced by our basal ganglia to perform that motor action. So typically, you're approaching this yellow light, you're running late, majority of the time you go through it. I know I shouldn't say this, but I probably would have gone through it in that circumstance. So for this social behavioral loop, if we're thinking about that same context of this situation, now we're going to identify relevancy. Okay, so imagine that your mother or your father or a family member's in with you. You're running late. You have to drop them off somewhere, and you approach this yellow light. Now, for instance, if my mother was in my car, she would, or grandmother, my mother or my grandmother, if they were in my car and I'm approaching this yellow light, I would stop. Because A, I have other people in the car I'm responsible for, and B, I would have been scolded. So that social aspect of our learned behavior influences this motor decision. So think about what would happen if you had someone in your car that you loved and you knew certain feedback or comments would be made if you made the decision to run the yellow light. And this emotional loop, again, is going from our reward seeking and our motivation with that influence of emotion. So we're going to see this a lot of the time in people who are seeking that reward. So gamblers are seeking that reward of winning money, but they don't have that inhibition to stop, or addiction. And this is the perception of experience too, with this emotion and a motivational aspect. So we also see facial expressions a lot of the times within this loop, and how our face is motor planning and moving to then relay what the emotion that we're feeding, or what we're feeling, not feeding, excuse me. So here on slide 26, we get into our non-motor loops. And our non-motor loops, we have our motor and our ocular motor. So with our ocular motor, this is seeing rapid eye movement, which is commonly, another term is called saccades. So saccades are these quick movements like reading. So for example, you can do saccadic movement. So if you all put your fingers in front of you, your right and your left finger at arm length away, stare at your right finger and then jump to your left finger and go back and forth as fast as you can 10 times. Okay? Okay, so that's saccadic movement. I usually test this in the vertical field, horizontal, and this is mimicking reading. So you can also test this by having somebody try to read if they're not aphasic and if they have their corrective lenses. It's kind of that clinical judgment of what you can do. But that's that ocular motor loop. So we're looking into our frontal and supplementary eye fields. And then we're looking at how it relates to our thalamic nuclei, which is our ventral anterior, and how it relates to the basal ganglia, which is our substantia nigra and our caudate body. And then within our motor loop, this is basically regulating the force of our muscle, how multiple joints are interacting to perform that motor movement, and regulating the sequencing and the contraction towards that. So obviously within our our cerebral cortex, we're going to have our premotor and our primary motor cortexes involved, and our precentral gyrus. The basal ganglia, the putamen and the globulus pallidus, is going to be providing that output regulation, that blueprint. And then within our thalamic nuclei, that ventrolateral one. So if the thalamus is something we're still unsure about, please go back and view or look at that PowerPoint I made, please. So movement disorders. So essentially, we have this continuum of hypokinetic and hyperkinetic. And so hypokinetic is when we're going to see our condition we're familiar with is Parkinson's. And Parkinson's is a very debilitating hypokinetic basal ganglia condition. This dopaminergic, I can't say that word today, neurons, essentially that substantia nigra is degenerating. And our substantia nigra, again, is in our brainstem. It's specifically in that midbrain. And what happens is the dopamine neurons that help with that transmission are being slowly degenerating. And what happens is there's 1 million people in the US that have this condition, and there's 6 million people in the world. So there's no cure for it. There's ways to regulate it, but it's a debilitating and sad neurodegenerative condition. So it's a neurodegenerative type. So within this type, there's two main categories. You can have postural instability gait difficulty, or PIGD. On page 309, that table 16.2 is a good flow for you guys to go and view to get a better sense of kind of the etiology, the overall prevalence of it, specific breaking down the signs and clinical conditions you'll see. But with PIDG, we're seeing rigidity. So as we've noticed, rigidity is just this over contraction of our muscles. So seeing it's an impact of tone. Drooping, or a flexed position. Tremors, this thing called pill rolling, which if you imagine in your hands and you've seen it, your hands are just constantly like you're rolling pills or rolling something in your fingertips. mask-like facial expressions because they're flat, essentially. They talk very quiet. They talk very slow. You can't hardly underhear them because they're just. Okay, so if you heard that, great. If not, that's basically verbal Parkinson's inability, that hypokinetic. Freezing. So when people walk, they stop because of the slowness of that basal ganglia inability to aid in that blueprint of movement. It's not that they don't know what they want, depending on if their cognitive status is still intact. It's just they can't move fast enough. They have a lack of an arm swing. You won't see that reciprocal pattern. Akinesia is another word that's associated, which means an absence of movement, or bradykinesia, which is slow movement. So on the PowerPoint, if you want to pause, please go watch the two videos, the Parkinson's disease and the Parkinson's symptoms. There'll also be more, watch those videos, please. If you have family members with PD, you know kind of what those symptoms might be like, if depending on if they're early or late onset, or if they're within the process of continuation. The thing with PD is that they have this thing called the Hoehn-Yahr, which is within your book. It's on page, let me grab my book real quick. This Hoehn-Yahr scale is something you will learn in dysfunction or phys-dys, but what it provides is a little bit kind of a timeline of how Parkinson's is kind of progressive. Let's see if I can find it. Pardon, one pause, real quick pause. So it's on page 309, and it's table 16.2. And this Hoehn-Yahr scale is essentially, it's a stage. So a lot of times the classifications of PD is done by this scale. And so please view that. And when you get to a 5, basically that means you're bedbound. You're so rigid with movement that you can't stand, you can't walk, you maybe can't feed or talk. I've seen one case of this, and this wasn't even when I was an OT student, it was when I was a certified nursing assistant. And they were basically kind of in that decorticate position with our flexed upper extremities, and they were total care. They were just total care in this Alzheimer's dementia unit because that's where that person was placed. They are at higher risk if they're at this stage 5 for contractures, bed sores, pneumonia, just because they're not going against gravity, they're not moving. So a lot of times at this point, a lot of it's a maintenance of our joints performed by nursing staff after the education following from a therapist. So that's how progressive and how debilitating this hypokinetic disease of our basal ganglia is. Soapbox is now done. So with our non-motor, we see depression, psychosis, and dementia. And again, this is just kind of our connection with changes just overall within our nervous system, just a degeneration. So hypokinetic, the second type is tremor dependent. So these are typically a slower progression. You're going to see more tremory movement with this type of PD. And it's usually due to the subthalamic nucleus just kind of overfiring all the time. You can still see rigidity and the slow, maybe that slumped over flex posture, but it's a slower progression. And typically, the treatment for this, first off, they start with pharmacology. So they're going to be doing L-DOPA or levodopa. Another one is called Sinemet, Sinemet. Sinemet is the main the generic. I don't know. Cinemet is the term for levodopa, but PT, OT, that deep brain stimulator that helps modulate. So putting those electrodes in the certain aspects of the basal ganglia, whether it be the globus pallidus, the caudate, depending on that, what they do is they test that with that person awake to see where they need to put that electrode in. The table on 311, please view that one for the treatment strategies. But for instance, a lot of the times the biggest impact is that functional performance of our self-care status. So OT, for instance, or PT can do Tai Chi. There's a lot of research done on Tai Chi and its influence of helping with maintaining movement and maintaining skilled, slow, kind of fluid movement is what they need. So instead of that rigid, we're trying to do flowy movement, I guess you could say. All right, and then another kind of program or specialization that you can get what's called LSVT, and it's big and loud. So big is part of the occupational physical therapy certification, and loud is the speech. And LSVT is trying to find the acronym of what LSVT means. It's the Lee Silverman voice treatment, is the loud, but LSVT big is the physical component of that within that program. And it's a certification that you can go through if it's I honestly would actually like to get certified in it, but it's this process where you just learn certain movements. Big movements is essentially what the research is finding, again, to help decrease those hypokinetic movements of the basal ganglia. So hyperkinetic is the opposite. We're going to see overactive movements, and one of them is this big one we know is Huntington's disease. Please click on the link to watch, but Huntington's disease is this hereditary condition that is impacting our autosomal dominance, and specifically in the striatum and our cerebral cortex. This is where you're going to see, chorea. This is all constant jerky involuntary movements, and what happens is you also see dementia related with this degeneration, with this condition. And usually after between 30 and 40 you become diagnosed, and about 15 years is when they're fatal. And what's happening is this globulus pallidus unusually is overactive, and it's causing jerky movements, and it's something you can be tested for if you have. Usually it's genetically related, so people who have had a mother or father or grandparent typically get tested for this if you wish, to see if you're a carrier or to see if you will have this. Dystonia, this is basically involuntary contractions, sustained contractions that cause abnormal posture, repeated movements. You can see with the posturing, you can see more swaying in the back, kind of a scoliosis appearance. In the video called Austin's Dystonia, it's a video kind of discussing the treatment process of this young kiddo who had dystonia diagnosis. And then another hyperkinetic is Tourette's or tics. So I provided a TED Talk there. It was a really good talk. I watched it. It's about this woman who gives a speech in front of people, and with stress and fatigue, your tics can be more prevalent, both motor and verbal tics. And so it's a really good video to watch if you've never had somebody with Tourette's, because there's a stigma with Tourette's that every person with Tourette's cusses or is inappropriate, and it's not the case. Tourette's is this physical overactivity of our motor and our language, and usually it's not a language, it's something that they're not thinking about, it's just something they want to say. Another person that had Billie Eilish, who's a singer, has Tourette's, the tic aspect of it, a motor tic, but we're having repeated words and phrases, actions like clearing the throat, blinking, twitching, just head jerks. So that's kind of what you see, these tics. And it's usually a childhood diagnosis. And again, like I said, it's exacerbated by fatigue and stress. So I encourage you guys, if you have some time, please watch this TED Talk. So another aspect to that is dopamine and norepinephrine are kind of the main, with Tourette's, kind of misfiring within our neurotransmitter understanding. All right, so on this slide, we're going to quickly talk about just the motor control, what the basal ganglia does. So facilitation is the red coloring of arrows, and the black is an inhibition. So the simplified summary of this is the basal ganglia, it inhibits the motor thalamus because it's got that black arrow. So inhibiting this motor thalamus allows for normal activity of movement for the motor thalamus, then to go to our lateral corticospinal tract, then to our lower motor neurons for voluntary muscle action. So if our basal ganglia is facilitating this, this is when we're going to see overactive movement, hyperkinetic involvement. If we see too much inhibition, we might see that hypokinetic. So we want to have the just right amount of inhibition from the basal ganglia. On the pedunculonucleopalatine nucleus, which is in our pons, what's happening is that this output from the basal ganglia is inhibiting this structure, which then the PPN inhibits our postural performance. So it's inhibiting this reticulospinal tract, which in turn is providing normal facilitation of movement of our posture and our girdle muscles. So it's controlling tone, essentially. So with this one inhibiting the PPN, which then inhibits the next movement tract, our postural tract, it's allowing for just normal control postural tone. So if we have a facilitation of that, we're going to see an over facilitation of tone, where we'll see rigidity of movements. For the third one, we're inhibiting this locomotor region in our midbrain, and what it allows for are these the reticulospinal, which is our extrapyramidal tract, which is not something we've learned, but it's normally helping and aiding in stepping action, so reciprocal movement. So if we have too much inhibition, we're going to see a slower of that movement. If we have extra, so our basal ganglia is facilitating this, we're going to have hyper movement. Okay, so we're kind of seeing a theme here. Our basal ganglia is activating movement when it needs to be and inhibiting movement when it's not. And this graph is just showing how it impacts these three structures. I think the first one we talked about, that motor thalamus, is able to portray that image of how to understand the influence of the basal ganglia. It's that blueprint. It's inhibiting just enough of certain movements to be able to have that activation of controlled voluntary movement through our descending tracts. If we have too much of our basal ganglia firing, we have hyperkinetic movement. If we have too much of that inhibition, we're going to have hypokinetic movement. So slide 31 is essentially the summary of the basal ganglia. Again, regulating force, sequencing multi-movement of joints, and incorporating the non-motor loops to be goal-directed. We can learn from it, and we have this emotional feedback. And then with these dysfunction of our cerebellum and our basal ganglia, this is when we're going to see things classified as movement disorders. And this is when dysfunction happens, is when we have an ear-regulating basal ganglia. So what is movement? So I'm simplifying this super easy, is basically feedback and feed forward. So movement is related kind of based on these two themes. So feed forward is when we're getting this adjustment and movement from our cerebellum and our basal ganglia. Since there are blueprints, we're preparing for an experience, is essentially we're feeding forward. So if you imagine when you go to sit to stand, what's your first thing? You move your head over your axial skeleton, your calf muscles are starting to contract to help with aiding, then you're having your lower body muscles firing, and that's that feed forward movement. It's a routine we've learned to initiate a certain unconscious movement pattern, okay? But feedback is how we change those patterns of movement based on experience. And this is because our ultimate goal is to stay upright. However, we get feedback from our vision, our nociception receptors if it's painful, our proprioception, our touch, our feel. We're getting all these different feedbacks. Like for instance, last year I fell on the ice. That was fun. So I got a feedback of pain and bruising from shoveling my driveway because I moved too fast and I fell. So what it made me do is the next time when I learned, because of that feedback I sustained from falling, I then learned that I need to slow down. I need to make sure I keep my base as support, or my center of gravity over my base as support, and doing shorter steps. So that's kind of how feed forward and feedback impact movement, because it's a learned behavior. We're constantly learning how to move based on our unconscious feed forward, but then the feedback we get to maybe change that pattern of behavior. And 34, we're on slide 33. The fundamentals of movement are essentially posture, ambulation, grasp, and reaching. So posture is this equilibrium. It's our orientation, which is our head and our body positioning. Our balance, which is basically maintaining our, like I've said before, our center of gravity over our base of support, so over our legs. And then our ambulation is the entire aspect of the flow of movement. We're going from our cortex to our BG, from our cerebellum, brainstem, spinal cord, to our lower motor neuron. It's that ever constant interaction of flow. But within ambulation, there's a cognitive component too. It's our attention. And we cannot overlook that, because the majority of the time when we're walking, we're doing something else. Our attention is divided. So when we learn about divided attention, we're learning about how we're able to sustain movement while doing a different task. So like dual tasking. So I encourage you and challenge you guys, the next time you're walking, to count back by sevens from 100. So I want to see what we do with this in the clinical setting is, while someone's walking or engaged in a task, you have them count back from 100 by sevens. And you start to observe their pattern of movement behaviors. Do they slow down? Do they decrease their step length? Do they just completely stop to focus on that task? Do they lose their balance? Do they reach out to grab something? So what's happening is that the body's compensating because it's being distracted. So it's not able to dual task. So if they completely stop, they cannot do two tasks at once. That's dysfunction. We typically are able to complete a motor action while we're doing some sort of other cognitive task. And then grasping and reaching is the connection between our vision, our somatosensory, and that precisional movement. For example, our lateral cortical spinal tract, okay? So that's giving that input of being able to coordinate those movements very, very fine-tunedly. And what's influences about this is that when we're children and we start to kind of move around and we're exploring with our hands, we don't necessarily have proximal trunk stability. We're just exploring our hands. So our lateral cortical spinal tract is developing kind of earlier on, but what it does is it influences our medial cortical spinal tract, that midline postural stability. So early handling aids in proximal trunk stability. And this is basically the summary of life for movement. So, this is just giving you that visual representation of how our motor circuits, our prefrontal cortex, our ascending and descending tracts, they all are integrated. They all have to work together for concise, functional movement. Okay. So just review that, kind of looking about how everything is involved here. Okay. It's not just one system does everything, it's an integration. And that's the most important thing to understand is when we're learning about movement, it's not just one system, it's a whole bunch of them. Okay. So then at the end of this lecture, I'd like you guys to go, and I've posted an assignment, a 2-question thing I'd like you guys to, you can print it off, you can email it to me, just to showcase your learning understanding from the cerebellum and the basal ganglia. So I'm going to post that underneath on Canvas right now for you guys to complete and have done by next Tuesday, please. It's just 2 questions. And thank you guys so much. I'm sorry this was a little long. Again, it's a lot of information. Pause, take breaks, split it up into 2. I appreciate you guys every day. Thank you so much, and have a great rest of your week and weekend. See you next Tuesday, and have fun in lab.